do you think kind of next steps in drug development, whether it's melanoma, might be based on biomarkers to help predict which patients could stop, or do you think it'll do you see any exciting biomarkers to kind of help make those decisions for which patients you're starting ipi-nivo versus PD-1 LAG-3?
Yeah, so a few things. Now we're talking about melanoma, and I know a lot about this, and I'm not sure if it completely applies to kidney cancer, but the data with nivo-ipi appears to be stronger in the BRAF mutant population for patients with melanoma than nivo-rela. So that may be a biomarker for who to treat. There's also data which I think is immature, and we'll have to see how this follows out, but that tumors that have high PD-L1 expression in melanoma appeared to do as well with single agent nivo as with the combination, indicating that if PD-1 is the pathway that's shutting off the immune system, that all you need to do is block that pathway to reactivate it. While the tumors with low PD-L1 expression seem to do better with the combination, indicating that LAG-3 in that case may be what's holding the immune system back. And once you activate the T cells by blocking the LAG-3 pathway, they're going to express PD-1 again, and the tumor is going to express PD-L1 again. And you're going to need to keep that blocked in order to work. So whether that actually pans out is uncertain. But it's relevant, I think, to kidney cancer, because most kidney cancer that even that responds to immune therapy is PD-L1 negative, even though there's an increased response rate in the tumors that have PD-L1 expression that represents only about 20% of the patients. With regard to stopping therapy, we're trying to use as a biomarker in melanoma PET scan negativity, and if PET scan is positive after a year, doing a biopsy to see whether there's any viable tumor. And oftentimes, if you've had a response and the PET scan is positive after a year, when you biopsy, you see no active tumor, it's probably just the immune system. And that may be true in kidney cancer. I think we're over-treating many patients with kidney cancer. In melanoma, we may ultimately switch to doing biopsies earlier. Instead of doing the PET stop trial that we're doing, it might be a path stop trial, and we might be looking at ctDNA or other imaging correlates that help us stop earlier. Not sure to what extent those things will apply to kidney cancer, which is less PET positive, and we're having a harder time developing a biomarker. But I'm sure we'll get there. There's some interesting approaches being tested in kidney cancer, and I'm hoping we'll be able to figure out biomarkers for stopping therapy, immunotherapy in kidney cancer as well. And that's really one of the major advantages over the IO-TKI combinations, where you really can't stop the TKI because the tumors usually come back.
Yeah, absolutely. Maybe now focusing a little more on kidney cancer, if you were given a LAG-3 drug and could put it anywhere in the kidney cancer, unmet need, where would you try to develop? What kind of a best case scenario do you think it would be most helpful for patients? Do you think starting in the resistant setting, maybe to your point that if you hit LAG-3 and you reactivate a PD-1, PD-L1 interaction, that would be a good for patients who've been resistant to frontline IO, or do you think it'll best fit in a naive patient population?
Yeah, well, we've not had great luck in developing second-line immune therapies in kidney cancer. And I'm going to get a little bit on my preachy pulpit right here and say that I think, in my opinion, as the data emerges from the IO TKI data compared to IO. It looks like those PFS curves continue to go down. They look like TKI curves, and they've gotten below where Nivo-Ipi is, even though Nivo-Ipi is 3 or 4 years ahead of it, a longer follow-up. And so I would say that IO TKIs are not in the long-term best interest of our patients. And if we still have a ways to go to increase the cure rate for patients with metastatic kidney cancer. And so I think the best place to put new immunotherapies is in the front line to try to increase that cure rate. So I would think an anti-LAG-3 should be tested in the front line, maybe as a triplet with a CTLA-4 antibody and an anti-PD-1 compared to Nivo-Ipi, and see whether or not you can actually raise the bar of patients who are responding, and those responses will lead to cures.
I love that
And
idea.
you're nodding. I think it's a good idea. You're interested in pursuing.
Yes, yes, and full disclosure, we're actively working on one of these type concepts. So totally agree. You know, I think it is such a need for our patients. We want cure. Our patients want cure. And so I think it's balancing and hoping not to increase toxicity. So thinking about how can we do this safely and still get that immune durability that we would love to see.
It's also becoming clear that the IMDC categorization does not really apply to immune therapy and shouldn't be used to choose your frontline treatment regimen. And so I think those trials in the front line should include favorable risk patients, and they should report out not by IMDC category, but by just the intent to treat analysis.
Yeah, I agree. And I hope that whether it's IMDC plus, biomarker or, novel prognostic systems, but I've heard many times, again, IMDC wonderful at prognosticating, but not meant to be a predictive. And so I agree, I think it should include all comers.